Hi, everybody. Today we're talking about Chapter 14, Challenges to Sexual Functioning. And really, ultimately, the chapter is about sexual dysfunction. And in a lot of respects, this chapter is going to relate to and borrow heavily from the medical model, a more disease oriented model with respect to diagnosis and treatment of conditions regarded and deemed sexually dysfunctioning. With sexual dysfunction, we're talking really about a few things that we can kind of assume from the very beginning. First of all, this is ultimately where the abnormal has become normal. We're talking about a pattern that typically in the medical parlance or the medically established terminology, typically we're looking at an abnormal pattern that has lasted for at least 6 months. So granted, there can be great debate about how long is ultimately the best qualification, how little, how much, how few. But then also a lot of this harkens back to how the individual self-defines their sexual experience. Are they ultimately satisfied? Are they ultimately dissatisfied? And this is also a social and cultural construction. So in cultures that are much more individualistic, like Western cultures, i.e. the United States, these are often framed in terms that are much more consistent with the medical model. But in more collectivist-oriented countries and cultures, that is often not the case. So we're talking about, again, where the abnormal has become normal, where there's some pattern of recurring difficulty establishing sexual function or functioning to one's ideal level of satisfaction. So what we're talking about is also falling under the umbrella of diagnostic and statistically manual disorders. And so, of course, now we're at DSM-5, and so sexual dysfunctions are also codified and recognized in the Diagnostic and Statistical Manual of Mental Disorders. So we're looking at clinical realities, ultimately. Clinicians of a variety of different sorts, be it from social workers to psychiatrists, can also work within these endeavors with respect to trying to eradicate sexual dysfunctions. Generally, the research indicates that about 30% of the adult population overall in our country currently experiences some kind of sexual dysfunction. And when we look at gender and sex, there is even greater disparity with respect to that. About 43% of all women in our country experience some form of sexual dysfunction. So we also know that, and again, the involuntary celibacy article that you all worked on for your first lit review is a great example of this. We know that sexual functioning, feelings of sexual sufficiency are an incredibly important part of one's quality of life. And so we saw that on the that one sort of opposite end of the range, where there's very little sexual engagement. We saw how much that was paired with despair, depression, loss of confidence, and so forth. So, and again, we also looked at the health benefits of sexual expression in Chapter 10. So, sex is positive. People know that it's good for them. It indicates good things for them. And so, to lack that or to have problems trying to engage it is incredibly difficult for a variety of reasons. And so, this is a good time to be talking about that in a good chapter to talk about that in. We have to look at some of the types. A primary sexual dysfunction is one that a person has always had. If a woman has always, for instance, experienced vaginal dryness, if a man has always experienced premature ejaculation, we're looking at that primary, one that they've always had. I would say the vast majority of sexual dysfunctions are secondary, that they arise through the life course after having a normal period of sexual functioning. We as a population, particularly as we get older, we put on weight. We're often not taking healthy lifestyle actions and behaviors. There's a high percentage of Americans who don't get regular physical activity. So all of these factor in and become some of the groundwork, unfortunately, for how sexual dysfunctions actually occur. We had talked about this before also with respect to Chapter 10. And sexual expression, that within the body, how blood flows in the body is critical with respect to readiness for the sexual experience and sexual engagement. And so again, this is a chapter where often one of the first signs that someone has a deeper problem, this chapter is indicative of that, is where they're having problems in the sexual realm. If they're having issues with high blood pressure, heart disease, they may experience a lot of that first or firsthand in a sexual context, right? So, in addition to the primary and secondary kinds of, or I should say, types of sexual dysfunction, you also have situational sexual dysfunctions, one that occurs in very unique circumstances. Say, a person may experience some kind of sexual dysfunction the very first time that they're with someone, each first time or each time that it seems to be that they may have that, or maybe there are certain physical positions that the body is in during sex that might bring about certain kinds of dysfunctions. You have others that occur in just about every sexual situation once there's the perception of that or of which. So we call these the global sexual dysfunctions, that in any kind of sexual situation or circumstance, it's where the individual experiences it. So these are some broad types. Again, there are more specific subtypes we'll talk about as well, some of which we know from the popular culture. We also can't leave out, and again, clinicians often will use these broad types, but in addition, rather, to the broad types, they'll also use some of the factors that are related to sexual dysfunction. We have physical factors as being one of the broad types of factors that are related to dysfunction. So with physical factors, we're looking at what physical state is the individual's body in. Are they, what's their status on a variety of different illnesses, disorders, and diseases? What runs in their family that, in addition to those illnesses and disorders, that might have a sexual consequence to it? What drugs are they taking? Those kinds of things, to be it to manage medical conditions, or are they taking these recreationally? All of those are consistent with the physical factors related to sexual dysfunction. Not to leave out, certainly we have the psychological factors. We're looking at emotions and what's the emotional state of the relationship of the person, if you will, the partners, the people within the relationship. Those emotions matter. Is the person depressed? Are they anxious? Are they fearful? There can also be within this psychological factor the expressed excessive perhaps need to please a partner. And so with that, we're talking about what can happen is if there's such a strong high need to please someone sexually or to offer a good sexual experience, often we get into what is known as spectatoring, where the individual feels like they're actually sort of judging or critiquing rather their sexual performance while it occurs. So obviously, there are some sexual dysfunctions, unique types that can be, if you will, or unique dysfunctions. Some of these can have multiple factors, that they can be have multiple physical and multiple psychological factors. And again, going back to the types, sometimes folks can have more than one type. They may have a primary and a secondary sexual dysfunction at the same time. And so again, these are the kinds of things that clinicians, social workers, clinical social workers, nursing, it runs the gamut in terms of the kinds of folks that might be working in this regard to ultimately diagnose and treat this condition and these conditions. And again, we're looking at, for the vast majority of people in this culture, we're looking at a matter of when and not if, in terms of these kinds of things occurring. All right, now we need to talk about some of the other additional kinds of broad categories and types. You have, for instance, your desire disorders. So here we're looking typically at low or absent desire in the vast majority of cases, where folks may say, in a sort of abstracted sense, that sex matters, but perhaps not really in a concrete sort of way. And so a lot of what you read about in terms of involuntary celibacy is a good example of that, where some of the involuntary celibates were with someone who really had a sort of hypoactive desire. They just really didn't have much of a need for sex, even though the partner, their mate, did and expressed a need or desire for it at very, very least. We also can't leave out the arousal disorders. And so with arousal disorders, we're looking at, well, do you feel or are you able to become aroused? And what are the manifestations of that? And so we're looking, in many cases, for women with respect to arousal disorders, we're often looking at vaginal dryness or inadequate vaginal lubrication, particularly during the aging process. So for men, we're often looking at erectile dysfunction as something that can also ratchet up possibly with the aging process. Orgasm disorders, we're looking here at those categories of conditions wherein orgasms are very, very difficult to attain or to sustain. Again, and so we're looking at female orgasm disorder, for instance. We're often, for men, looking at delayed ejaculation or premature ejaculation. And there are a number of techniques. The squeeze and the stop-start technique with respect to premature ejaculation works quite well. But again, some of these take or are a bit more invasive, or they may involve a bit more systemic workup, if you will, from a clinician. And so again, being open to resolve these kinds of circumstances and concerns is incredibly important, again, given the high percentage of American adults that may experience it at any given point. We also can't leave out pain disorders, and so we're looking at slight to very severe pain that may occur upon the onset of some kind of sexual experience, often we're looking at penetrative kinds of sexual experiences that can bring this about. And so the pain, again, to truly be acknowledged and to truly be treated, it has to be, again, subject to exposure to a clinician, and the options, in addition to the classification, have to be paired systematically to make the resolve that much more likely. Some of the best kinds of ways to combat or to ward off sexual dysfunction possibilities include regular physical activity, regular exercise. And so getting exercise for at least a half hour a day, most days of the week, some kind of cardio, light to moderate intensity or more cardio, at very least that light amount, most days of the week for a half hour each time. That's going to be incredibly significant for combating, if you will, the possibility of dysfunctions that might be related to cardiovascular health and other kinds of related health conditions. I remember a study from years ago that showed that men who walked briskly 20 minutes every day, if you will, during the week, they were very less likely to have to take or avail themselves of a vasoactive drug like Viagra or Cialis. Because again, what was happening was the cardiovascular activity they were getting, connecting with the walking, allowed them to get the blood flow and the blood circulation throughout the body, and clearly to the genital region, which enabled them to have the optimum sexual experience sought. Also, in addition to regular physical activity, simply being open to a variety of approaches that can be very promotive with respect to sexual health. So being willing to see a therapist, particularly one that specializes in sexual dysfunctions, being willing to perhaps even go to a group therapy kind of experience wherein these kinds of things can be talked about and discussed in a peer context, that can be very, very helpful as well. Obviously, certainly being open to vasoactive drugs, and a lot of that can be broached with conversation with medical professionals like a physician or like a nurse practitioner. So in so doing, the openness and the availing of oneself to these kinds of modalities can be particularly not only helpful in terms of getting sexual functioning reestablished, but also can be re-enriching once that functioning returns.